Okay, so hello everyone. I think we'll start uh, while people are still connecting. So thank you very much to be part of this webinar about the supply chain government. We'll have Sanjay as the moderator today, but also three major speakers, Dr. Boniface, Miss Henrietta, and Dr. Andrew. So I will give the floor to Timmy to say hi on the behalf of IPHL before we give the floor to the moderator, Sanjay. So hello, Timmy. Are you there?
Yes, I'm here. Thank you, Nati. Good afternoon from here, everyone. I had begun on the chat that it's 1 p.m. in Nigeria, and I have seen 3 p.m. in Ethiopia. And Andrew, we can't even tell what your time is in Australia. But we want to say thank you to everyone for joining us today. Um, we decided to put this across to begin to delve into the issue of governance, because in different webinars and forums that we have had people with interest to talk about governance, the things that put everything that we do within the supply chain together. And we have thought about how we can do this. There are several ways we could, but we decided to bring this webinar to us to see how we can begin to scratch the surface. It's such an enormous conversation. We are certain and we are not confusing the fact that we can do justice to it on just one call, but we want to begin the process. So we had looked into the database of IHPHL and the ecosystem of health supply chain. And we have brought to you some representation of the finest in the field of governance and human capital development. So we have Andrew, we have pharmacist Henrietta, we have Bonnie to join us today. And we are happy also to have content partner, Sanjay, to moderate this very important webinar. I want to encourage all of us to dive into the conversation. I'll be on the chat to see how we are engaging. And then after the webinar, the listserv is still open for us. The different platforms in different countries are still open for us. So let us take advantage of it and see how we can make this better and make our work better. Thank you. It's over to you, Nati.
Thank you very much, Timmy. So Sanjay, you have the floor. Just let me know if you can see the presentation well, and we'll start the slides.
Yeah, thanks, Nati. Can it be a slideshow mode rather than yes? Yeah.
Let me see.
Do we have the poll ready, or that is for later?
Yes, we have the poll already, normally.
Okay, excellent. So thank you, Timmy and Nati. And first of all, I'd like to welcome all my fellow speakers. It's really great to be part of this webinar. And welcome everyone from wherever you are joining. This is a very important topic, from the perspective of overall health systems. But today we are going to focus very specifically how governance matters within the public health supply chain as well. And we will take you through not just what it means, but we will also look at governance from different countries' perspective and in general, looking at it from a high level, the implications, the issues, and what happens when it is good and what happens when it is not that good. But before we begin our session, there is a quick poll for everyone, which I would like Nati to launch on screen. Okay, is it better, Timmy? I hope it's better. I can be a bit louder as well. But there is a poll on your screen, and I would like you to read the question and select the most appropriate option. The first question is, how would you rate your organization's current supply chain governance? There are 5 options you can select based on your observation and experience of working in your country and organization. And the second question is, what is the most significant challenge your organization faces within the sphere of supply chain governance? So there are two questions. We can select quickly a couple of options based on your observation, and then we can move forward. Neti, do you want me to show the results first and then move on?
Yeah, we can give 1 minute for people to respond. We are at 42% for now. If we can reach the 70% to have a clear view of the poll.
Okay. Excellent. So just to make the poll a bit more clearer, the idea is to understand from you before we begin this session, because a lot of people may understand governance in different ways, and hence may understand different governance challenges as, sometimes operational challenges or something else. So today, one of our efforts is to also ensure that you understand what are some of the key governance challenges, and this poll is an effort to reflect on those issues. Nati, whenever you're ready, you can launch the results. Then we
Okay.
can move on.
So here are the results.
Okay, excellent. So majority of you have rated the governance in your organization as good. There are very few who have said poor, and about 39% are saying fair, which means there is a good scope of improvement. In terms of the second question, I think the biggest challenge that people are facing is inadequate technology, and then training, relationship management, and transparency are some of the other issues, governance issues, which you feel are there in your organization. Okay, these are valid points, and then we will look a bit more into these as we hear from some of our speakers. Next. So we've already discussed what is the objective of today's webinar, so I'm not going to go too much into it, but the webinar will flow. The webinar will flow in a way where each speaker will talk about a specific governance topic, and then there will be questions taken from the audience on chat. Because of the time constraint, we won't allow you to speak, not possible, but we will take the questions from chat, and the speakers will respond to your questions. At the end of when each speaker speaks, after that there will be a panel, and we will take more questions from the overall webinar, and the speakers will respond to those questions. And then eventually, hopefully, once the webinar is finished, all this will also be posted on the IAPHL listserv. Okay, let's move on. I don't need to introduce myself, but very quickly. Okay, it seems my audio is not that great. Let me check. Okay, I hope it is much better now. So I am a health system strengthening expert. I have worked in various countries, and in the last few years, I've been working predominantly on workforce development, e-learning, training and development. Today, I manage BeSkilled as a CEO, which is an e-learning organization, and we support NGOs, governments, and various other implementing partners in creating e-learning pathways, not just in supply chain, but also in other health system areas. I will just keep it short. I will introduce other speakers as we go to them one by one, but let's quickly go on to the first slide, Nati. Yeah, move on. Yeah. So we'll start with what is governance in supply chain, a basic introduction before I hand it over to the first speaker. So next slide. Yeah, as you can read on the screen, governance refers to oversight of the structures and processes that enable the direction and control of a system, organization, or a country. It can be governance can be at various levels. It eventually guides power sharing or relationships amongst various stakeholders and orients the responsibilities and actions of individuals, departments, groups, and organized sub-organizations within it. But just to process this definition, this is a definition, but just to process this definition, governance is sometimes also looked like leadership, uh, but leadership generally, we use this term leadership to reflect on the top management of any company, or people, or just people who are taking decisions of any organization and system. But when it comes to governance, it becomes a bit broader, where we also look at how these decisions will impact the entire system, and how these decisions are taken, and what are the implications of those decisions to the entire system. With in perspective of health supply chains, as you see these circles on screen, um, governance would mostly be about taking these decisions, which will eventually impact how any health supply chain is managed and run. To give you a bit more in perspective, I will take an example. So as you see on screen, one of the circles, it says allocating funding resources. So imagine a situation where the central procuring or warehousing has to procure a new batch of product. But while doing that, they realize that there is a funding gap, so that in itself creates an issue, that is a governance issue. To if we put it into perspective, it's not really an operating issue, but it's largely a governance issue, where the top management of any system or any organization, they need to decide, and they need to identify various funding streams and allocate those funding resources accordingly, for procurement, for all other operational expenses within supply chain, be it distribution expenses, be it warehousing expenses, or for that matter, any human resource expenses. So the decisions that are taken with respect to allocating these resources, how those resources need to be allocated, the timeliness of it, all those decisions collectively, when taken, that falls under governance system. Similarly, setting policy standards, relationship management with stakeholders, monitoring and evaluation of systems, risk management, identifying roles of different partners, stakeholders who are collaborating together in a system, defining their accountability systems, and eventually ensuring sustainability, which is a very important topic in today's health supply chains. So all these encompass what we say governance, and eventually they they affect how supply chain functions are operated. So this is a basic idea of what governance is. What we are going to do next is listen from an expert, health system expert, supply chain expert, Dr. Andrew Brown. And Nati, if we quickly go to his bio, I will connect the dots with the topic as well. So Dr. Andrew will talk about, sorry, first of all, Dr. Andrew has more than 30 years of experience in health systems, from pharmaceutical systems to HR development in low and middle income countries. He has worked all across the world in Asia, Africa, Pacific, and today he is the senior principal technical advisor at MSH. So he will take us through a portion to understand how these different relationships within a system, they need to be managed for a better governance, for a better governance system of not just health supply chains, but also an overall, looking at an overall health system and taking a health system perspective. Nati, sorry to keep going back and forth, but if you can just go to that, yes, here. So that is the first section of today's webinar, where Dr. Andrew Brown will not just talk about some of the concepts and applications of governance, but we will also talk from the perspective of overall health systems, how different relationships, stakeholders, they need to be looked into collectively when talking about governance in supply chains. So without further ado, I would like to invite Dr. Andrew Brown on the stage and take us through to the next section. Uh, Andrew, you have about 10 minutes before we start the Q&A. Thank you.
Thank you so much, Sanjay. Thank you, Nettie, and thank you, Timmy, for that introduction. And welcome to all the IAPHLers. Next slide, please. As Sanjay said, governance is a very big area, so I'm going to focus on a couple of aspects of governance. I think of governance in terms of both the structure as well as the elements that Sanjay said about how that structure takes place. Next slide, please. One of the things that we think about is this pharmaceutical systems pathway, which includes aspects of supply chain and pharmaceutical systems. And ask yourself the question as you reflect on Sanjay's thoughts, where should governance be? And governance is important across the whole system. There are different stakeholders, there are different leads, there is different interactions, and pharmaceutical systems needs strong governance throughout the whole system in order for medicines to not only be available, but for resources to be used appropriately, medicines to be of quality, and also medicines to be used well. So I want you to think about the key takeaway is governance is a critical element of pharmaceutical and supply chain systems. And we often don't give it enough time. Sometimes we think about governance meaning corruption or governance meaning something like that, and we move away from the topic. But governance is all about the systems and the approaches we use to have smooth running systems and to get best out of our resources. Next slide, please. So one of the questions we ask ourselves is how do we actually make this happen in a particular country context? And one of the ways, and if you had the opportunity to read the background notes that were given by Timmy and his team, are national pharmaceutical units. So these are units where the government of a particular country is the steward or the custodian of responsibility. They govern. We know about the governance, we know about governors, we know about politicians. But in this context, we're talking about a structure and the people having the skills within it to do certain things across the pharmaceutical system. And we would talk about this in 4 ways. We would say there's governance for pharmaceutical regulation, medicines regulation, governance for end-to-end supply chain, governance for pharmaceutical services, and governance around pharmacy practice. And different countries look at this in different ways, but over the last few years, what's happened is governance around pharmaceutical systems has fallen off the agenda of discussion. Next slide, please. So one of the things that we were thinking about is that there's this narrow thinking about pharmaceutical systems in some countries with governance, just thinking about supply chain. There's this fragmentation between different parts of government as they govern pharmaceutical systems, but also there's limited guidance and experience. Next slide, please. So to help with that, there's a couple of things we want you to think about. I'm going to put in at the end of my talk a little link to our extended webinar on this, which also we have a 20-hour course on this topic. And so an hour today is just tidbits. But let's just say, take Kenya quickly. In its structure, it's got a Directorate of Health Products and Technologies under the Ministry of Health, but then separately a Poisons Board, National Quality Control, and Medical Supplies Authority. So these are different structures that govern these aspects of the pharmaceutical system. They need to talk and communicate and work together to be efficient. Let's take a look at another country. Next slide, please. Let's have a look at Côte d'Ivoire. Côte d'Ivoire has a completely different structure of governance, but has the overall same stewardship responsibilities. It's got a public laboratory. It's got the Director of Health, which looks after the Directorate of Pharmaceutical Activity. It's got its regulatory authority, and then it's got its National Order of Pharmacists and its National Public Health Pharmacy section. So again, in Côte d'Ivoire, there's a different way that governance is sliced and diced. And so in this context, there is different communication that needs to take place in order for, again, medicines to not only be available, but quality medicines for them to be able to be used appropriately and in the right place at the right time. Next slide, please. So as we think about this, I want you to think about the pharmaceutical system, which includes supply chain. At MSH, we like to think about everything in the pharmaceutical system from that clinical discovery right through to the patient use and pharmacovigilance. And think about the structures and people and resources and their interactions. Think about this sort of equitable, timely access and appropriately and cost effectiveness. This is what we're trying to achieve with good governance. And think about these four components: medicines regulation, procurement, distribution and storage, selection and rational use, and pharmacy practice. Next slide, please. As you think about your country context and where you work, ask yourself the question whether these following elements are present in your system. And for each of these slides, I'm just going to talk about the high-level blue statement, and you'll have these slides later to go into more detail. But the first recommendation that we've had from our work, where we did literature review, some case studies, and had an international panel of experts to consider some thoughts, was that an NPSU must have a clear legal mandate to steward the pharmaceutical system. So there needs to be a legal mandate. Some countries don't have this mandate, and so governance cannot take place. There needs to be a legal mandate. Next slide, please. The next thing to think about is that the medicines regulation or medicines and technologies regulation should usually be a separate semi-autonomous governance. And the reason for that is logical when you think about it, because this group is responsible for the quality of medicines, not the purchase, the quality. And so having quality separate from purchasing reduces conflict of interest and allows us to be more confident in that. And so this authority to regulate medicines being separate is another aspect of governance. But think about that these groups have to talk together. Next slide, please. Another high level is that procurement and supply chain management needs to have a high-level unit in the ministry and have this overall end-to-end stewardship responsibility. In a number of countries, this means actually conducting and running supply chains, but in many countries, it means having private sector or others run supply chains that government governs. They have the authority to procure and to manage, and they have that oversight. Another aspect of governance involving coordination that you might not have thought about is what about the governance where government entities interact with private sector, whether that's 3PL or 4PL providers. There needs to be a governance structure in place and communication for those relationships to work well. Something that's very important when we're thinking about governance of procurement and supply chain management. Next slide, please. Another area of recommendation is pharmacy practice. And this is an area, if you're old like me, you'll remember WHO discussions about essential medicines lists, about national medicines policies, and aspects of pharmaceutical practice that ensure that the right medicines are not only available, but used well. And this is an aspect that we want you to think about. Is this present in your country? Is there a unit in the governance structure to do that? Next slide, please. And as we come to the last couple of minutes, there's a couple other things I want you to think about. Motivated by Sanjay, where he said, Andrew, what's about that communication? I've already mentioned that there is aspects of communication within governments around the different entities and their role in pharmaceutical systems as well as supply chain. But on this particular slide, it gives you an overview of how we can look at strengthening pharmaceutical systems. And I want you to notice that we have providers, we have government, and we have community. And it's not only structures and so on within government that need coordinating. There needs to be coordination of private sector, of other implementing partners, of faith-based sector, as well as community and patients that allow us to understand each other's needs, understand where problems exist, and understand how we can do better at the supply chain. And this happens when there are open, transparent, good governance systems in place. Next slide, please. And to conclude my 10 minutes rapid fire, I want you to get your mobile phones ready and take some clicks of some of these QR codes. For each of these QR codes, there's a deeper resource that's available free of charge for you around, there's a 10-hour course, there is a conflict of interest material, and there is also a technical material which includes an IT approach for indicators to see How good is your governance? How strong are your pharmaceutical systems? Next slide, please. So as you think of these resources and approaches, I want you to use this as a fire starter to your mind about governance, and you know where to go to get more information. Sanjay, back to you. Thank you.
Thank you, Dr. Brown. Great. I would say this is a great primer for anyone who wants to begin understanding what is governance in not just supply chain, but overall pharmaceutical systems. Dr. Brown, I have a couple of questions for you before we move on to the audience. You talked about good governance a few times during the last 10 minutes. It would be great if you can explain to the audience what could be some of the indicators for good governance in a country when we look at overall pharmaceutical sector like you presented?
Okay, thank you. So indicators is an area that is perhaps a little bit more difficult, but I'll pick a couple for you. So one of the indicators initially is whether there are structures in place. So are there structures in place that have the mandate and the responsibilities? Then some of the yes/no indicators is the legislation in place to enable those structures? Another indicator is whether the minutes and the decisions of these different governance bodies are actually published and open to the public. This is a transparency indicator. Another indicator is of these particular groups that meet, particularly those that are responsible for funding allocation and those responsible for approving and not approving medicines. Is there an open and transparent process of conflict of interest, which is where perhaps people on that decision-making committee have interests or shares in companies or other interests that may cloud their judgment? And a good indicator would be if those committees have conflict of interest policies and that the actions of conflict of interest are declared so that others can see in an open and transparent way. Just a couple of thoughts there, Sanjay. Back to you.
Yeah, no, this is what I was looking at because for a lot of our audience members, it might be very difficult to put a perspective of, yes, you've talked about all these structures at a country level, but then what does it mean? How do we check whether they are governing in a good way or not? So that's why I asked this question. The second question that I really want to ask you is, you talked about 4 different functions which can be managed through these various NPUs, which can be standalone parastatal bodies or which can be somehow embedded within a Ministry of Health. Now, what would be a good way for any Ministry of Health or any centralized body to have a full visibility on these various functions in a way that they can oversee how these different NPUs are governing their respective functions?
Great. No, thank you for that. I'll give you the example of Uganda and Kenya, where on their websites of the ministry and of the bodies, they have advertised very clearly, and I'm sure other countries do the same like Nigeria. I'm not saying that other countries don't have this, but these are just 2 that I'm aware of because I read them a little bit recently. They have a overview and explanation of the roles and the responsibilities of the particular entities. They have an overview of the governance structure, so who are the people in authority, and generally how they work. That would sort of be a minimum, so people understand who's responsible, what their roles and so on are. Then the extra points organizations would get is if they were doing the other, as I said, if they were publishing minutes, even if they were abbreviated minutes of meetings, or particularly summarizing decisions that were made, etc. So anything to add to the transparency would be good, but the minimum would be that explanation. And the best approach is to be able to have more around transparency and conflict of interest, as I noted earlier. Thank you, Sanjay.
Excellent. Thanks, Dr. Brown. We are almost at the end of 15 minutes for you, Dr. Brown. So maybe if there is any question from the audience which we can take in the last minute. If not, then we would have to move forward. So very quickly, I'll just wait 10 seconds. if any
Just note
questions come
Jeffrey's
up.
comment while we're waiting there, Sanjay, that
Yeah.
where Jeffrey's noting that the availability of policy and legal frameworks is definitely another indicator.
Indicator,
Can you imagine a country where a medicine is counterfeit and is killing people, but the government hasn't got authority to remove it from the marketplace? That exists, and I was involved in such an incident. So thank you for that.
Yeah. Okay, I don't see any further questions, so maybe we move on to our next speaker. So Nati, if you can quickly go to the bio of Madam Bakura. Sorry, it's going back
No,
and
no
forth.
worries. We'll do that.
Yeah, so I would like to introduce our next speaker, Madam Henrietta Bakura-Onyeneke. She is the Director and National Coordinator for the National Product Supply Chain Management Program, NPSCMP, which is part of the Federal Ministry of Health in Nigeria. She is a visionary leader in public health supply chains and has 2 decades of professional background in pharmacy practice, health supply chains, and other similar areas. She's also an associate fellow of the West African College of Pharmacists and a certified supply chain analyst from leading Nigerian university and other professional associations like ISCEA. Her exceptional leadership and dedication earned her the Thomas Sankara Leadership Prize as Pan-African Woman of Courage. And I believe, I know her from the past few years, and I believe the way the federal government in Nigeria has decided to make health supply chains more structured and inclusive in the country, her role at the helm of NPSCMP is really important, and it would be great to hear from her how that is happening, and that creates a great segue from what Dr. Andrew Brown talked about different NPUs. Nettie, if we go to her section now. If you remember Dr. Brown's presentation, as he talked about different functions in the health system may have different NPUs. Now, in this case, we will hear from Madam Bakura with the case of Nigeria, how governance of national supply chain is happening in the country, in Nigeria. Because Nigeria is a very large country. It has both centralized and decentralized structures from federal ministry to state ministry. And it will be great to hear from Madam Bakura how these different structures are being coordinated at a federal level by NPSCMP. So, Madam Bakura, I would hand it over to you for your section. Thank you.
Thank you, Sanjay. Good morning, afternoon, everyone, and my fellow panelists and all the participants on this call. I'll just take it off from the last speaker, introducing to us and setting the tone for the discussion on this webinar. So I will want to just limit myself around who should govern the national supply chain with the Nigerian perspective, learning from Nigeria. As we all know, governance is very key for management of supply chain activities in this instance, from the planning stage to the procurement, to the warehousing, distribution, and ensuring that the patient gets the needed for patient outcomes, and so that we have value for money. So in one sentence, I will just say that governance is being able to do the right things rightly. So having said that, that links to us having policies and standards and the enabling tools for every implementer in that ecosystem to be able to implement accordingly. So for the Nigerian perspective, the government in its wisdom decided to set up the National Supply Chain Program for obvious reasons, so that there'll be sanity, so that there'll be a referee that will be able to coordinate the management and the systems of health supply chain. And that has been able to happen in terms of ensuring the right structures are being set up, right from the national, the program has been set up, and it did not just stop there. It went and cascaded down to the state level, whereby we have the coordinating body on that, and whereby it was set up through the LMCs, the Logistics Management Coordinating Units, and also to all the LGAs in country. We were able to achieve a lot of progress with that design, ensuring that every of these levels of tiers of healthcare have their mandates, but in an independent manner, they are able to still link up with the national. And with the national, because you and I agree or must see to the fact that in any football team, there must be a referee, there must be someone that will say the game goes on or stops or kinds of allowance and ensure that the game is played according to standard. And that is the role of the NPSCMP. So we as the national have that control and have that mandate to be able to do what? Produce and formulate, develop supply chain standards. The standards can be the policies, it can be the guidelines, it can be the SOPs, it can be the templates, it can be the standards on HR and lexicon. So having done that, we also know that in terms of business model, being that we have a supply chain strategy plan and that it is public health inclined with a business model of ensuring financial sustainability. At the same time, it takes into consideration ownership. So we also are mindful of the fact that at every tier, the business model is applied. Now, at the state level, they also have that mandate of managing and ensuring that they are able to prefer and provide in accordance with health strategic objectives of that state to be able to provide the necessary healthcare products that the populace needs at that time. They are also controlling at the LGA level those that have the hands-on mandate to be able to administer appropriately drugs that are quality, that are efficacious to the patient that takes it. They don't just stop there, they also have to document all forms of adverse drug reaction. They also have to document based on inventory management and policies on ground and make sure that it is given to the upper ascent level for a supply. Now, the end, if you have shown the next slide that has the picture of how this one stream of service is connected, you see that at the end of the day, what we want to achieve is universal health coverage. Universal health coverage attributes, we want to be able to make sure that medicines and other healthcare products are available, availability of healthcare commodities. And then we want to ensure the cost is affordable in line with universal health coverage. We also want to make sure that there's equity and that every populace, every Nigerian is not disadvantaged in order to get the necessary health outcomes. So having said that, we also are ensuring that the NPSCMP as the controlling body, as the visionary leader for supply chain in Nigeria, from time to time, looks at how the policies and strategies and all those standards are being implemented. And then it looks at the current situation and looks at whether there are gaps towards fulfilling the mandate of the strategy in this instance is universal health coverage. And then it develops and make sure it fills the gaps in terms of knowledge gaps. And it does that through thought leadership, ensuring that it proposes and submits this as the coordinating forums that are being on ground from time to time and meet for periodic updates in terms of collaboration, in terms of tactical, whereby fundamental issues are discussed. And then even in terms of lexicon, we define and say, how do we describe this? How do we describe this perspective of supply chain? We get to hear conversations around supply chain, around private sector, around public health, and then we bring all stakeholders together to be able to put on the table some of these definitions in a way that every of the stakeholder will now make inputs, and then we adopt it for use. Now, in terms of national oversight for the national programs that we are overseeing, and I'm talking about in this instance probably the HCM, that's the malaria, TB, and HIV programs. We are also aware of the fact that it's a routine for them, based on their mandate, to ensure that they manage health commodities that will bring the required end user outcome for their teaming recipients of care. Now, if, for example, a program is operating at 50%, what NPSCMP is supposed to do is assessing the maturity of those programs and seeing the gaps. And then we now profile how do we up their maturity progression to improving from 50% to 60% to 70% and so on and so forth. So NPSCMP also is able to benchmark different entities, in this instance national programs, and also with the state capacity ownership program, whereby DMA states are also assessed to be able to see how we can improve their state health supply system. And in that maturity, we grow and support them and ensure through change management they are able to progress. And when they reach maturity ready to integrate for integration, we optimize the system. So invariably again, NPSCMP serves as a visionary leader, and it from time to time comes together to redesign any change that needs to be designed in terms of providing the necessary service that we need to provide out there to our populace. So by and large, we also keep eyes on key performance indicators. It's not, it's not objective to be implementing without putting our eyes on what do we want to achieve. So in terms of governance, we ensure stakeholder management, inclusivity to every extent you can imagine. Every person that needs to be in the room is there. It could be the CSO, civil society, it could be the private sector, it could be all those multi-sectorals that we want to ensure they are in the room. And we see that happening in terms of even state supply system functioning now. And states are adopting that, and we feel that that is the way to go, ensuring the conversation is one, ensuring that we are all meeting with one purpose of aim to ensure that we get to the target that we want. So in doing those and in meeting and looking at putting our eyes on the key performance indicators, we ensure commodity management through availability of not just that they are available, but that they have quality and that they can be afforded. And then we have the end-to-end supply chain solution, whereby we have the data repository, and we use that for informed decision in terms of good procurement practices. It could be in terms of good supply planning to ensure that the utilization of warehouse infrastructure and other health systems infrastructure on ground are adequately utilized. And in that way, we can be able to also monitor for performance and see how our service providers that will ensure last mile delivery is met and every of those indicators are met in terms of satisfaction by the provider and the beneficiaries of these providers. So NPSCMP leads in terms of leadership, it leads in terms of governance, in terms of providing what is needed for the implementer. It could be the academia, it could be the national program, it could be the states, and so on and so forth, who are also using these standards that we develop from time to time and we review with every stakeholder on board. So setting up the program in terms of our mandate, in terms of the structures we have on ground, in terms of the design that we need to meet with one stream of service, which the strategy has provided and is prescribing is what we use. Recall also that before we became where we are, reach where we are today, we have been having various forms of intervention from the development world. It could be the Global Fund, it could be the BNGF, and through the ESM Nigeria, whereby maybe through, I'll call it the Regency, they improvise and be able to implement that aspect of ensuring that the strategy is being implemented through the blueprint also. Because if you don't have the blueprint and how you are going to implement this strategy, you will not be able to allocate resources adequately. You will not be able to monitor and understand what you are monitoring. So for us in Nigeria, this structural setup and these different strategies that we have been using in country is what we have been using to ensure that the different tiers of governance in terms of healthcare are coherently linked, but yet they are independent. And then through that stream of supply, we intend to deliver service for universal health coverage come 2030. Thank you, and over.
Thank you, Madam Bakura. It was a great, rundown from how, for a country like Nigeria, which is really large, and you can see on the screen that there are 40,000 health facilities, so many local government areas, LMCUs, 37 states, different programs, how all of it needs to be governed at various levels. I have a couple of questions before we move on to the audience. So I would really request the audience, if you have any questions, please put them on the chat. But a small question to you, Madam Bakura, is what is the system that NPSCMP follows, where they provide technical support to the state LMCUs for them to also strengthen their governance systems at their respective states?
Okay, thank you, Sanjay. So another bit I maybe didn't mention is the fact that the mandate of NPSCMP has been tweaked a little. Remember, I said we are not too rigid, we are flexible, because we want to see that if there are gaps in meeting out and in ensuring an efficient and effective system, we redesign. And one of such is the transformation that we are embarking upon, ensuring that state health supply systems are built. And the state health supply system is not just about the LMCU, it's also about the DMA, it's also about the steering committee, it's also about the state committee. So all of that is nipped up to give you the state health supply system. So what we do is we already have developed our algorithm in how we can be able to assess state health supply system, and then we understand the level or the maturity level they are. And then if, for example, they are on emerging, or they are maturing, ready to integrate, or yet to reach anywhere, we now put in the plans on ground to say, okay, you are rudimentary. What do you need to be supported with to be able to move up to the next level? So that's the format in which I told you, like I said, we have been having support like from ESM Nigeria to see how we support the states in terms of how they build the state health supply system to a matured level that we hope will get them and make them potentials enough for them to mature to integrate with the public health program, essential program. Remember that the strategy, what we want to attain is we want to reduce cost of running the supply chain, and we can only do that through an integrated manner. And so that is one of the strategies that we have employed to say we are supporting states to be able to mature, and using integrated last mile delivery, they go along with the public health donated commodities with their essential medicines program in a way that it will reduce the cost, and then at the same time leveraging on the DMA structure in terms of quality, in terms of reduced cost, using full procurement and MOUs and so on and so forth to have volumes for crashing down the cost of their medication. So this is how we have been doing and supporting. So far now we have 21 states that are drug management agencies, and we deploy most of these strategies to support them going forward. But we need more fund, we need more collaboration from every funder if anybody is really interested in following up to issue of sustainability for health supply chain in Nigeria. That's what we do.
Thank you, Madam Bakura. I see a couple of questions on the chat, but I think it would be better if we take those questions during the panel. It was a great section taken by you, Madam Bakura, talking about Nigeria. Let me very quickly take us to the next third section. And before I do that, I would like to introduce the speaker. Natty, if you can go to Dr. Bonnie's bio. So, yeah, the bio, sorry. Yes, excellent. So the next section will be taken by Dr. Boniface FUNDAFUNDA. He is the co-CEO at Africa Resource Center, and he focuses on, the ARC focuses on external engagement, growth, and strategic partnerships. He has helped shape the role of ARC in its advisory services to government across the African continent. While before ARC, Dr. FUNDAFUNDA has over 25 years of experience working in the public and private sector across different global health domains, with a special focus on policy and planning, strategy, business development, and other operational systems. Some of the notable roles of Dr. FUNDAFUNDA would be as the CEO of ZAMSA, where he led the transformation of infrastructure and operations for health product storage, warehousing, and distribution across the country. He was also the technical advisor to the Ministry of Health of Zambia, with a focus on access to medicines. He has been an advisor to various ministries in Sudan and other places, and he has authored several books on supply chain as well. So, without further ado, I would invite Dr. Boniface FUNDAFUNDA to take us to the next section. Nettie, if you can take us to that particular section.
Thank you. Thank you very much, Sanjay. Thank you, Natty, and thank you and welcome everyone. While we're waiting for the slide to go, I think I'll generally just look at our own experience in terms of the few things that we find in the course of our work to help and assist governments in creating an ideal situation of ownership of supply chain in their countries, and therefore leading to creation of resilience, which is what you will recall, especially on our continent. This has become a very prime subject, exercising practically every government, and certainly through the African Union and all the bodies such as our regional economic communities, who are all tasked with ensuring that member states have got resilient supply chain that can withstand the shocks of such events as the pandemic that we just went through. I think from a starting point, I might say that the subject of governing supply chain, we should look at it from the perspective that historically on the continent, we really haven't had, an agreed recognition that supply chain actually is important in public health. I think, generally speaking, one might say that supply chain was always seen as an activity that takes place, but, it is either done by the central medical stores or anyone else can do it. Whether you look at the starting point of, say, what's happening at a district level, you might say anybody can manage supply chain, whether it is any other healthcare person or anybody assigned to the task. And this has been more or less I suppose the consideration or the position that we find in many countries over a period of time. But I think increasingly with these new expectations and with all the attention and investments now being put into supply chain, you see, and you recall from what Andrew started us off with, describing exactly what's the infrastructure of supply chain. It's not just the logistics angle of it, but it's the totality of everything that starts even with your planning for your products, budgeting for your products, procuring them, and then putting them through regulatory affairs, as well as then, warehousing, storage, and distribution. That totality is what really comprises supply chain. I think then in all of those aspects, you probably have a lot of performance indicators that must be monitored and considered in terms of improvements and so forth. So I think the starting point from our experience in terms of advising the many countries that we are supporting and even holding our sessions with the regional economic communities, one of the things that we are pushing for is recognition of appreciation of what is it that you are governing, right? So when you talk about supply chain, what exists within the public health sector infrastructure to say, here is the supply chain service, and here are the players responsible for the activities, and here is the leadership and the structures that ensure that supply chain is taking place. Yeah. So without necessarily focusing on the central medical stores, because that's always the easy way out, is to say we have a central medical source, it does supply chain. But the people are governing supply chain don't necessarily, it's not necessarily the central medical stores, it's everybody else who is affected by it. So I think if we can start with appreciating of what is it that we need to govern, then we are on a track to ensuring that we set up the appropriate governance structures. I think Madam Bakura also spoke about the responsibilities, the sovereign responsibilities of the government to be the lead that speaks about supply chain, that invests in supply chain, that creates that world framework. And in doing so, we pull in a lot of partners, of course. And that is just the value of where we are at in our development of these public health services. We have a lot of partners, we have a lot of resources that can enable the governments to realize the responsibilities that they have as the lead for supply chain, and the government therefore becomes the central point where we coalesce or we align in terms of all the advisory services that we are providing. I think in that respect, we are looking at issues such as having policies in place, having your supply chain strategies in place, having your implementation plans that speak to who does what across the whole supply chain, from planning for your medicines, budgeting, all the way to dispensing of medicines to a patient. That whole structure has to be described. It has to be institutionalized in such a way that we can identify who does what across the whole supply chain. I think quite often we simply, again, in some governments, there are roles, but the job descriptions are not really specific. So things are left to interpretation. So when you talk about, say, a supply chain officer who is responsible for health product supplies at the district hospital, what exactly does that mean? Because you might find that this person only has that general description of the role, but there is no proper job description that says your scope of work on a daily basis is to do X, Y, Z. You are accountable for these things. Your tasks are these. You are responsible for that, and you'll be therefore monitored based on these elements. In the absence of that kind of focus, again, we are open to interpretation, and we are open to difficult things like inability to take sanctions, because we don't know who is responsible for what, because we do not generally make those specifications. So in the specifications which need to come from the leadership all the way to the service delivery point. Those are the sort of things that I think we are also seeing, and we are also trying to emphasize that they need to be deliberately put in place, because therefore with that in place, then you can have abilities to govern and manage the supply chain clearly. And as I said, those responsibilities as to who does what also applies to all of us who are partners to governments, whether it is implementing partners on the ground, whether it is development partners who are funding and supporting government to put in place these things. We are all expected to be aligned around a strategy of government, and therefore we are meant to uphold the government and really, together, working together through, again, a governance framework to ensure that the objectives of the government are being met. And of course, we need to also be very clear about what we expect from all of this. What are we expecting from the government structure, governance structure rather, it's not just to look at sanctions. It's not just to ensure that there are plans there and there. I think we also want to see that we are creating a resilient supply chain at the end of it. If we can also have in mind that if you take into account what Andrew spoke about, and what Madam Bakura has mentioned in terms of the infrastructures for supply chain, I think the totality of all of that taken together must result in a resilient supply chain that provides benefits for public health programming and has direct benefits to the patient. Because otherwise, then all of these things has no purpose, really, if we are just putting structures in place without looking at what the end result must be, better health outcomes for the country, because supplies are in place at the right time in the right places. The very odd mantra that all of us should know about. So I think, in short, this is what, from our advisory perspective and convening perspective, this is what we are seeing, that as much as the resources are available, the information is available, we still find that creating these things in some of our governments is still a difficult situation. We still have certain focus at central medical stores, which can do the work, it can move things, etc. But the people are, in touch with supply chain and are often not included in this whole process. Even you find that the ministries of health, there may be a person who is in charge of supply chain, but that's just one person, right? There isn't really like a structure within the government establishment that says these are the supply chain officers or people looking after medicines and other health products. And that is their career structure. This is their training program. This is their budget, etc., etc. We still have to negotiate for these things to be in place on a daily basis. So I think in ensuring that we put these instruments in place, then governance, I think, will be well capable to be done. Otherwise, I think it will be a continuous game of negotiating with each unit in the ministry, each unit across what we make say the supply chain, and all the other stakeholders who are affected by this service will also be struggling to make their impact because there isn't something that is clearly coordinated, clearly governed, clearly led by the entity of government. So I think that's I'll end there and maybe take some of your questions, Sanjay. Over to
you. Thanks, Dr. Bani. I think one of the points that you touched about as supply chains being resilient, I think that is that should be the goal for any country or any national supply chain. However, a key issue that I see, or rather a key challenge that I see towards becoming resilient is that a key factor that ensures resilience is continuity. And that probably is one of the biggest issues in national supply chains, because most of the times they are governed by government offices who may keep on going from one department to the other. So from your experience and from your experience of working with different governments, how can supply chain governance be made more, it can have more continuity in terms of people who are governing it?
I would say maybe a simple answer to that would be, as you reflected on it, the mere fact that supply chain as a function and as a process within government, you find in some of our countries, it isn't in the establishment of, say, the Ministry of Health. There will be people who are responsible, say, for supply chain. But like I pointed out, you might find that there's only one person in the department of, the ministry. Maybe it may be a pharmaceutical department, but that person cannot be the sole person who is the supply chain structure in the sector. I think what you are looking at is ensuring that there is a whole development of personnel that are responsible for operations of supply chain across what we call the supply chain up to the service delivery point. I think if we can establish those structures, then I think you have anchorings that you can touch on and points in the supply chain that you can monitor, you can invest in, you can develop, and you've got career paths for people who can begin to look at supply chain as something that is interesting. I mean, one of the things that we've been discussing with colleagues in Kenya is looking at the Kenya Institute of Supply Chain, which is the body responsible for training supply chain officers and ensuring that all of us who are working in Kenya and supporting supply chain recognize that entity as a government entity responsible for creating these officers. But with all of that training, we must find that in government institutions like the Ministry of Health, there is a supply chain department or a unit where these people can go and perform their roles. Even at institutions such as KEMSA, there must be like supply chain officers who have got a structure there and are able to perform those tasks. So in the absence of this kind of recognition and investments, you still have supply chain being looked at often as an afterthought in everything that we are doing in terms of access to medicines. We can talk about practice, we can talk about procurement, quantification, and so forth, but to get things moving and manage all of these things, you do need to have this kind of structure in place.
Yeah, excellent. There is one more question that is quite relevant to your topic, which has come on the chat, and Daniel, sorry, I can't pronounce that name, it's very difficult. He's asking, how do we navigate governance, considering institutions, organizations are at different levels while adopting policies, and sometimes there is a variation in policies as well.
So again, I would refer to what Madam Bakura articulated, which is the sovereign responsibilities of the government in form of the Ministry of Health or the Federal Ministry of Health to shape what the agenda is for supply chain for that country. And I think as a duty of all of us who are then working in the public health sector, whether it is development partners, whether it is NGOs who are contracted to do services, we have to recognize that centrality and ownership of these plans and strategies of government. The moment we start creating vertical arrangements, because we can, by the way, because we have the resources to do so, we are completely then confounding the position of government and really making it difficult for government to lead. So the duty is not necessarily that we should be called upon or be asked to join. My goodness, we should be able to say the responsibility of government is to create this infrastructure and we align around it. I mean, I've worked in countries where you would be kicked out for not aligning with the government policy or strategy. You will be expected to provide new ideas, innovations, and so forth to enhance that position of government. So whether it's a government, is another government department, whether it is, say, a regulatory office, whether it is an NGO, etc., it still comes back to the fact that there is one Ministry of Health that takes the lead, and we are supposed to enhance its leadership and work with it, by all means criticize and so forth, but at least it starts from recognizing that complete responsibility and ownership. There's only one entity, and that's the ministry.
Thank you, Dr. FUNDAFUNDA. I think without wasting too much of time, I would request all of our speakers to come online so that we can answer some of the questions which are coming on the chat. Some of the questions that are listed were also I was going to ask, but let me take some of the very important questions that has come up. One from Dizalim Mekonnen from Ethiopia, I believe. He's asking, in today's volatile global environment, what innovative approaches to supply chain governance can be implemented to mitigate risks like pandemics, natural disasters, or political instability? I think this is a very crucial topic within governance of risk management, which is very, very highly overlooked. So I will request all our three panelist speakers to, either provide some examples and also talk about it from your own experience.
I think if I can go to that, I think one of the most interesting that has arisen from even this last pandemic is just the value of creating partnerships, working together at a very high level, whether it's among development partners, with, you know, and the government bringing in those partnerships. I think that's what has become for us something that we recognize as what people are working towards. They recognize that we can't do, you know, we can't do resilience for supply chain if we are not working together. So there's a very great interest and a demonstration of that interest to work together in partnership with the government. I think that's really one of the mitigations here.
Okay. Okay, so if I can add to what the last speaker said, in terms of collaboration, it will go a long way. And not only that, communicating doesn't just mean dropping mails or stop at that. It also entails you even making phone calls at the back end, and not that, co-creation, coming together, both the government, the private sector, plan together from the early planning stage, and then work together towards implementing whatever work plan that has been put. So co-creation, planning together, and extensive communication will go a long way. Understanding that we are fighting one giant or challenge in that way. So not everybody doing their thing, but everybody in the room engaging and mapping extensively those that need to be in the room for that conversation and discussion to make a headway. Thank you.
Thank you. And Sanjay, if I could just add just a quick comment before you move to your next question. In our SSCS project in Uganda, one initiative that was taken there was under the government's One Health policy. So for those who are not aware of that, that's bringing together the Ministry of Health, Ministry of Agriculture and Fisheries, and also Ministry of Livestock, Agriculture and Fisheries, and also the sort of environmental health. And in that environment, they put together a formal structure. And Dr. BONFACE mentioned this in his talk as well, the importance of these formal structures. And within that formal structure, there was a mechanism for these people to come together, these different groups. And as Madame so nicely described, it's not just the coming together, but it's the communication. And then within that project went further that with that communication to co-create the supply chain systems and the understanding of what's needed to prepare for upcoming pandemics. And should a pandemic come again, how will the necessary products be procured under emergency statutes? How will they be distributed in a timely way, particularly when workforce is unavailable? And I think this pre-preparation is what is something that we don't do so well. And this was a good example of moving in that direction. Thank you.
It's like those drills that military does. So there is a bomb threat. So they are doing drills. There is no bomb threat, but they're doing drills. So I think that is what also is needed in today's health supply chains. It's like drills. It's like pre-planning. So that's a great thought, Dr. Brown, and I think everyone can learn a bit from that. There's a question about donations, which I would like to slightly modify. I think donations is a big issue in many countries within Africa and Southeast Asia, because a lot of donations come into the country, whether for civil society or through UN, and sometimes from various philanthropists as well. And a lot of times, and from my personal experience as well, a lot of these donated products go to waste. What can be some of the decisions or governance mechanisms at a national level to manage these private civil society or even UN donations?
Oh, this is something I've had a lot of experience with in different countries. Can you imagine being confronted with two 40-foot containers of 100,000 different bottles of medicine with nothing matching? Not only did it not get used, but it cost thousands of dollars in resources to dispose of and to sort. And there was only a couple of people in the country had the ability. So again, it comes back to governance. When you think about what comes into a country, a government must let into a country things. Donations don't turn up. They have to come through customs and so on. So the strong aspect there is to have the governance and the policy in place. What is the donations policy of the country? But then to be able to put that into practice. Now, where I think things come unstuck sometimes is there is a political aspect and a cultural aspect to donations, where some cultures and some ministers of health and so on feel that they and want to accept donations without thinking through all of the implications, because they want to develop a relationship or they want to acknowledge that generous support. But I think part of our role as supply chain and pharmaceutical experts is to educate the ministry and those around us that it's quite appropriate to set the criteria for the donations and to be able to say no. It's not offensive because it costs you thousands of dollars. For example, Aceh, we're celebrating or commemorating, I think it's 20 or 30 years since the Aceh tsunami. Can you imagine 10 football fields of warehouses full of pharmaceutical waste that the government had to dispose of? Just picture 20 football fields of warehouses. So policy, governance, but we need to be aware that there is lots of reasons why people accept donations, and that strong governance structure and awareness I have found helpful, but just from my experience. Thank you.
Thank you, Dr. Brown. Any other response? I will just end with one more question, after which it will end.
Okay.
Yeah, Madam Bakura.
So in addition to policies and governance, I think accountability frameworks. For us in Nigeria, we have developed a document where we have assigned roles and responsibilities across board the supply chain elements. So when it comes to donation, like you said, of course, every country is expected to have a donation policy. You may need to have on ground the monitoring aspect, whether adherence is there, and if there's no adherence, are there sanctions, and so on. So a lot of documentation, a lot of follow-up in terms of monitoring of the implementation of those policies will go a long way. But most importantly, availability of those accountability frameworks will go a long way. And then routine engagement with the players, those that are supposed to use them, for them to understand the importance and the negativity of their actions if it is not followed through. And then if governance is really followed to the latter, especially if they are under your control, because there's something you call authority. You don't have authority to discipline probably a stakeholder that's in a process. But if it is in your domain to discipline and sanction, I think that is when the full wrath of some disciplinary actions can be taken on erring officers to serve as a measure of alert and concern, or say a red flag to other people to desist from from not adhering to such policies, because most times those policies are there. It's not as if they are not there, but are they followed up? Some are there. Is there awareness? So it's still infringing on the governance aspect for timely, periodic dissemination, reminders of such accountability documents, so that most of these issues can be put to rest. Thank you.
Thank you. Thank you, Madam Bakura. And I have one last question, which I think would be very helpful to all the audience. And this goes to the experience of all our speakers, because we have worked in various countries at different capacities. Now, more and more, we see that in countries, supply chain has a very is becoming a very multi-stakeholder initiative, where there are multiple donors. Different donors have different programs led by different implementation partners. There are different technical assistance bodies. Then there are different consultants sometimes. Then, of course, apart from the national supply chain, there is a faith-based network. Sometimes there's a civil society network. The question here is, to all of you, is how can a body like a Ministry of Health, under which there might be a Department of Pharmaceutical Services or a Central Procuring and Warehousing Agency, how can this body manage this multi-stakeholder environment effectively?
I can start off with an example of Kenya. I think in 2019, the Ministry of Health issued a directive to all the partners working in the health sector, calling for setting up of an interagency coordinating committee, fairly high level, committee of all these organizations that were supporting public health. So I think for me, again, it goes back to the ministry taking ownership and recognizing that it is responsible for coordination of all the partners who are providing support. So by enacting that kind of directive, the Kenyan government called on all the partners to come together, irrespective of whether they are, they are international organizations or they are local organizations such as the church health associations, as you mentioned. So by just simply calling for that coordination, it also reminded everybody that, yes, there is actually a need for coordination, and there's a need to work with the government as the lead entity in the country to ensure that all the investments coming into the sector are coordinated, all the activities are coordinated, and even the reviews and such, they are all coordinated around the entity of the ministry as the lead office in the sector. So I would say it's again demonstrating that leadership by taking that line of action, by pulling together everybody around this, setting up a round table, as it were, for that sort of partnership and coordination. Thanks.
Thank you. So just to quickly add that, yes, governance is there, and once the entity that has that mandate of supply chain in the country is identified, it rests upon you to be able to give the necessary feedback to the leadership. So given the Nigerian perspective, we have coordinating platforms that we have these partners, funders, any form of intervention that comes into the country. We meet periodically, I think biannually, and then we put on the table everybody's intervention. And then we are able to project to them where we are with what is happening, happenings that are ongoing in country. And then we're able to tell them and show them, okay, this investment, this is what it has been able to bring on board, the output of it, the impact, and then guide them appropriately. And when we see there's a kind of replication, we say, why don't we integrate and do it in this better way? So it goes a long way if you have those collaborative structures whereby you have all those managers and the funders that have the envelopes to spend, and then you guide them based on country outlook, and then based on also ensuring that their mandates are met. So it's a kind of sense, it's a 50-50. You need to also meet their expectations, and while also the country's expectations are also considered. So if you have a round table periodically and you subject issues on ground in terms of country-wide approach holistically, you'll be able to navigate around having any of interest going out of scope, or interest not being made, or putting funds where you will not have value for money. Thank you.
Just a quick addition is to say that a lot of development partners, of which MSH is one of the really value-add activities, and I'd be interested to hear Dr. Boniface and Madame's respective, is anything that projects can do to support the secretariat of these meetings. Often the hardest thing is to have the regular secretariat functions. Kenya and Nigeria are very well established, so perhaps less of an issue, but in many countries, just getting resource together to be able to bring people together for meetings, and the administrative aspect of that is not always possible in a busy ministry environment. And so having the structure in place, yes, but then having what's needed for the functions of that administration to take place is a vital aspect of success. And I just want to come back to a point Dr. Boniface made. If you remember, one of his opening remarks was, I think he saw that someone got kicked out of the country for not doing the right job. And I asked myself the question, how many ministries of health really feel that they have that clout and ability to do that? And how many of us as donors and implementers are fearful of that in a positive way, so that we really want to get behind Madame and other country leaders to support them with what they want to achieve in their supply chain? Thank you.
Mhm.
Yeah, Dr. Brown, let's all go to India and we'll see that.
Indeed.
Excellent. Thank you so much, all the speakers. It was a great interactive session, learning from all of you. Natty, I don't know if we have time for the poll, but maybe you can just launch it. And in the meantime, I will say thank you to everyone for listening to us. I really appreciate all our speakers. And at this time, I would hand it over to Timmy for the closing remarks. Timmy, over to you.
Thank you, Sanjay. Thank you very much for taking the charge for this session. I really appreciate your moderation.
Timmy, it will be
And
good to see your face.
okay, sorry. Thank you. It's a bit dark now, but can you see me now?
Yeah, yeah.
Yeah, I want to say thank you very much for the coordination and the moderation of this session. Thank you very much, Sanjay. Thank you, Dr. Bonnie, for getting on the call to join this conversation with the different country experience that you've had. Dr. Brown, I thank you for joining too, even though it is already 10 p.m. or 11:30 in your zone right now. But I'm grateful that you were able to keep awake and you are acting as if it is just 10 a.m. Thank you so much. And of course, to my able national coordinator, Pharmacist Bakura, thank you for yielding to this call and for sharing very practical experience from Nigeria. I'm happy to hear the progress that we are making. And of course, to every one of us that have joined, you know, the fascinating thing for me is that we were at 85 at about 2 minutes to 2 p.m. my time, and we had gone well above time, and we are still 83 at this time. I do not take that for granted. I really want to appreciate your patience with us, and it's also alludes to the fact that this is a very important topic that we are all very interested in. And as you will notice, the tempo is even just graduating further. That means we have not done the required extensive justice to what we need to do. So the conversation continues after here on the list itself. You can ask questions. There are links that have been provided to extensive webinars and courses. Please dive into it. When there are questions you need to ask, come back to the web list and let us know about it. If needs be, we can make arrangement for a callback. We bring Dr. Andrew, we bring Dr. Boniface and Pharmacist Bakura again. Let them come and give us the real practical approach to governance within the supply chain. So I really want to say thank you. I appreciate your support. It's right now 30 minutes, 2:30 here, and I just want to let us go. But Natty has launched another poll, so I would like you to just do this last poll as we close. As we launch the poll, you can unmute and just tell us something you want to tell us that you two are calling at 11 p.m. your time, so that we can also appreciate you. Anything, just unmute now. This is a free house. While we're at that, you can interrupt me at any time. I want to bring to our notice that the IHPHL has launched an open hour that happens every Thursday. Every Thursday, you can come in using the link every Thursday just to say anything, to connect, just to get feedback, provide feedback for us. It's an open hour. We have done 3 editions now, and then we have gotten some very fantastic feedback. We've had people call from South Sudan, Ethiopia, and the US. So please take advantage of the moment. As we make progress, we will be inviting resource persons to be on the team so that you can ask personal questions. We recognize that some people don't want to send mails, they want to talk. So that's why we have launched the initiative. Thank you very much. You will notice that my background is very fantastic. That is the new and coming IHPHL logo. And I also want to get your feedback as regards to that. All right, it's back to you, Nancy.
Where it is coming from, so I really like it.
Thank you. Thank you
And
very
I
much.
would play my favorite song during the open house because you have said we can do anything that we want.
Oh, yes. Go right on.
Thank you.
All right. Thank you so much, everyone. Bye from my side.
Thank you. Thank you very
everyone.
much.
Yes.
Bye.
Thank you. Bye.
Bye. Thank you.
Bye.
Bye. Bye, everybody.
Bye.
Bye.
Bye, everyone.
Thank you,
Thank
Michael.
you.
Thank you.
Madam Bolajoko, thank you very much. I can cite you.
Thank you.
Thanks, everyone. Bye.
Bye, Godwin. Bye, Francis.
Yeah, such an insightful meeting. Thanks a lot.
Thank you. Thank you.
Yeah, thank you to me. Thank you, everyone. Thank you.
Thank you,
Well
Kelechi. Thank
done.
you.
Thank you,
Well, to
Timmy.
the
Thank you
organization.
very much.
Well done.
Ogataju, thank you very much. Thank you for
All right,
me.
bro.
Thank you.